Hi guys, let's do the GIGU lab. I'll throw it on YouTube, do the demo in class tomorrow. This week is kind of messed up anyway with the schedule swap. I'm sure you won't mind. The abdominal palpation part 1. Remember last week we did percussion. Now we're working on palpation part 1. It's the winter, 2022. It's week 7. Here we go. Now I have demos on this, so you can go to these links to see me actually doing this on somebody. Make sure you know how to do this for boards and for my test. Palpation is used to check for masses, to look for something called muscle guarding, to evaluate. Next week we'll evaluate the size of liver, spleen with this technique, and also used to confirm percussion findings that we did last week. So there's 2 types of palpation. If I say do general abdominal palpation, you're going to search every nook and cranny of the stomach, all 4 quadrants. So assess all 4 quadrants. Patient will be supine. Doctor will be on the right side of the patient. There's 2 types of palpation you have to do. If I say do general palpation, you'll have to go twice around, doing light palpation first and then deep palpation. Or I might just say do deep palpation. Or I might say do light palpation. But before you get started, make sure you get informed consent. Tell the patient what you're going to do and ask permission. Make sure your hands are warm. Make sure their knees are flexed. If the patient is ticklish, you can use the patient's hand and put your hand over the patient's hand for doing these techniques. Sometimes it's just difficult to do if they're ticklish. And if they have specific regions of pain, like maybe at McBurney's point, do these last and do that region last. So first we have light palpation, and you're going to search all 4 quadrants using a circular motion. You're going to push down into the abdomen, but not very far, about 1 centimeter. You're searching really the skin and the subcutaneous layers. You're not looking for deep things here, but you will search every nook and cranny. Watch the patient's face in case they grimace, but you're probably not going to get any pain because you're not going that deep. You'll also search the umbilicus too. So you want to put your finger in the belly button to look for Sister Mary Joseph's nodules. So this is the pattern. So you start here and swirl around your fingers. It doesn't have to be exactly in this pattern, but you should search 4 quadrants. As long as you cover every nook and cranny of each quadrant, more of like a triangle up here because of the costal margins. Don't go over the costal margins like some people did last quarter. They were like way up here in the ribs. I'm like, what are you doing? The abdomen is underneath the costal margins, so stay underneath there and search all the quadrants. Simple as that. You're looking for rigidity, masses, areas of tenderness, muscle guarding. Normally, of course, the abdomen is soft and smooth and there shouldn't be any pain. We should know the difference between involuntary and voluntary muscle guarding. Involuntary is called rigidity. One of the quadrants will be spasmed. Maybe the whole abdomen may be spasmed, but it's usually one of the quadrants will be spasmed, and it's a reflex to protect some type of inflammation. When an intestine gets inflamed or an organ gets inflamed, it's damage. It's easier to damage, so the body tries to protect it, and that's a reflex spasm. So you might not be able to touch them, you won't have a lot of pain, or you might feel a spasm. What causes it? Inflammation of an intestinal organ. It's on the way to peritonitis, so this is a refer to the hospital situation if you find something like this. Bowel obstruction will cause inflammation of the bowel, so really it's just inflammation that causes this problem. Yep, everything I said, it's an involuntary protective mechanism. And these patients are going to be sick. They're going to be vomiting. They're not going to be feeling good. They probably won't be in your office. They'll probably be in the hospital. Now, they might have voluntary muscle guarding. So they're purposefully tightening up their abdomen because they don't want you poking into an area that they already know is going to hurt. So they're purposefully doing this. This is usually a prelude to involuntary muscle spasm. So you can coax them into getting their muscles to relax, maybe bend their knees even more and see if you can do it. It usually indicates inflammation. It's an early inflammation from obstruction of a bowel or peritonitis or polyp. Something is inflamed. It could be cold hands. Maybe you just have super cold hands, or they're anxious, they don't like being touched, or they're ticklish, or they're faking it, malingering. And yep, it typically progresses into involuntary spasm. Remember we were observing for things on the abdomen, and we saw Sister Mary Joseph's nodule, but we weren't sure if it was in a outie belly button or maybe an umbilical hernia. This is the time where you palpate the belly button. Remember we said Sister Mary Joseph's nodules are hard as a rock. They're cancerous. Umbilical hernia, you can push it back in as long as it's not incarcerated and inflamed. But the Sister Mary Joseph's nodules are typically not painful, and they're hard as a rock, and that's not a good sign at all. So make sure you assess. This is an umbilical hernia. You'll be able to push that in, no problem. This is the Sister Mary Joseph's nodule. She thought it was a hernia. It isn't. It's cancer. It's stage 4 cancer. Cancer's gotten into the umbilical plate and growing there. Very bad diagnosis. Now we go to deep palpation. So warn the patient this doesn't feel the greatest. We're looking for things deeper, not bowel obstruction. We might be able to feel it if the patient lets us. Aneurysms, tumors. We also use it to feel the liver and spleen, which we'll cover next week. So again, you're going to investigate all 4 quadrants. This time you're going to go much deeper than 1 centimeter. You're going to push down, and you're not going to use circular motions. You're going to use a back and forth motion like this, and you're going to push deep. So maybe 2, you can usually cover each quadrant with 2 or 3 of these back and forth motions. And yeah, it doesn't feel good. You're going really, really deep trying to find things. Up in this, the liver is right in this region, and the spleen and stomach are up in this region. It helps if you have the patient exhale when you do this, so the diaphragm gets out of the way. If they inhale, it's going to drive the liver and stomach down into your palpation zone. That's going to be more uncomfortable. So have them inhale or exhale. And yeah, warn the patient. That's going to be uncomfortable. We said back and forth motions. Have the patient exhale. Everything I said already. Remember what the liver is. The liver is hanging out right over here. Shouldn't never be more than 3 centimeters from the midclavicular line over here. There's the stomach in the other quadrant. Just so you can remember what the parts look like. Again, it's normal for tenderness to be over the organs, the cecum, sigmoid colon, aorta, xiphoid, which is by the xiphoid. If patient's really obese, you might have a lot of trouble going deep like this. You might have to use a 2-hand approach for some extra power, and that's acceptable. You would use that same pattern though for that. And if you do find a mass, make sure in your travel card, in your SOAP notes, you mark what quadrant it was. Try to estimate the size of it. Is it intraperitoneal or extraperitoneal? I'll show you how to do that in a second. And is it pulsatile? They go to the ER if it's big and pulsatile. So because you might check it out. Maybe they go to the ER and they blow them off, but they come back in and you do another exam 6 months from now, and you see this little warning in your travel card to recheck it to make sure it hasn't grown. So if it's intraperitoneal, that means it's probably the intestine. The mass is deep. If it's extraperitoneal, that means it's in the subcutaneous tissue, like a cyst or something. So the way to test that is feel the little, let's say it's a little ball-like, feel it, and then have the patient contract their abdomens, have them do a crunch or a leg lift if they could do it. If it's intraperitoneal, inside the peritoneal cavity, it'll disappear when they contract their abdominal muscles because it's deep. If you can still feel it when they're contracting their abdominal muscles, then it's extraperitoneal, it's less worrisome. Then it means it's in the subcutaneous tissues. Probably a cyst. It still needs to be checked out. Could be a cancerous tumor, but probably not. Probably a lipoma. Now palpate the abdominal aorta. Very important. I'm going to ask a lot of you to do this on the exam. With the abdominal aorta, you always want to do this in people over 50. Normally the aorta is not greater than 30 millimeters or 3 centimeters. Average is about 2.5 centimeters. It's below it's halfway between the xiphoid process and the umbilicus, just a hair to the left of the midline. I think we did we try to auscultate this already? Yeah, we auscultated for bruits, so you know where it's located. You want to keep the fingers apart when you do this. You also can have the patient exhale, especially if they're a little obese, to help this area relax. Let's look at how to do it. And you can watch my video, or I can demonstrate tomorrow as well. But this is how you do it. The xiphoid is right here. Belly button is right about here. And you sink both fingers down, leaving a big gap in the middle, like this picture. And sink down, have them blow the air out, and you sink down as they blow the air out, and feel. If the patient doesn't have too much adipose tissue here, you should be able to feel it. Probably 80% of you could actually feel it like this. And it shouldn't be much wider than this. If you put your hand way over here and sink down, and you can feel it on both sides, that's not a good sign. It's way too big. So it shouldn't be much more than about 5 centimeters. Right, so that's how you do that. That's the only place you do it. You don't do it anywhere else. If there's going to be an aneurysm, it's going to be right there between the xiphoid and the umbilicus. It's right underneath that renal vein is where it occurs. Right? So what do you feel? Beside it pulsating, it might feel like a purring cat as well. And that's turbulent blood flow. A normal aorta will just feel like a pulsatile nature. If it's really big, you might feel this purring cat, which is a thrill. They go right to the emergency room. If I felt one and it was big, I would refer them to the emergency room just to make sure. But definitely make sure they see a vascular surgeon. What are the risk factors for aneurysms? Males, smokers, over 65. And if they're relative, if there's been a abdominal aortic aneurysm repaired in the family, that's a huge risk factor. Alright, so that's it. Short and sweet. We can demo this tomorrow, or you can watch the video. It's up to you. See you guys later.